In the final section of our lecture, now we will talk about some miscellaneous conditions that can cause obstetric emergencies. In these miscellaneous conditions, we will talk about eclampsia and umbilical cord prolapse, shoulder dystocia, and also thrombosis and thromboembolism. First, eclampsia. Eclampsia is a hypertensive disorder of pregnancy characterized by vascular dysfunction and systemic inflammation. So if during the antenatal visits, if patient's blood pressure is constantly high on different visits, then it's important that they should be carefully monitored and they should put on some antihypertensive medicines that are safe during the pregnancy to avoid eclampsia. So it's hypertensive disorder which develops even in women who have no previous history of high blood pressures. They develop hypertension during pregnancy, and it should be managed properly. They have high incidences of developing high blood pressures later in life also when they have gestational hypertension. So this is hypertensive disorder of pregnancy characterized by vascular dysfunction and systemic inflammation. Risk factors include hypertension and high blood pressure. Prenatal care visits are important to take care of this condition. Patients who do not have routine antenatal or prenatal care visits, they usually come in emergency, and because they already developed eclampsia, and they come with seizures and eclampsia. So this is important that they should have regular prenatal care visits. If the person is obese and the priming gravida, that should be also is a risk factor for developing eclampsia. Signs of eclampsia, we have epigastric pain and headache, which is common with high blood pressure, hypertension, hyperreflexia and clonus. Reflexes are high and there is clonus present. Facial edema and papilledema, swelling of on examination of the eyes, there is papilledema and there is swelling of the face also. Agitation and poor urine output is another sign of eclampsia. Management is senior help is very important. Focus on airway, breathing and circulation. Anticonvulsant like magnesium sulfate should be given. And antidote 10 ml 10% calcium gluconide. So all these are the management steps for the patient who develop eclampsia. Amniotic fluid embolism is another condition that can be obstetric emergency, very serious emergency, because usually it has very high maternal mortality rate. So amniotic fluid embolism, due to amniotic fluid that enters into the maternal circulation, cause acute cardiorespiratory compromise of the mother. Disseminated intravascular coagulation occur. Difficult diagnosis, usually diagnosed at postpartum. So diagnosis is difficult. When the amniotic fluid enters the maternal circulation, it can cause disseminated intravascular coagulation, and it can cause cardiorespiratory compromise. Signs are maternal collapse, chest pain, cold, dizziness, panic attack, nausea, vomiting, breath shortness, and paresthesia. So all these are the signs of amniotic fluid embolism. Management is structured ABC approach. ABC is for airway, breathing, circulation. Look for airway, breathing, and circulation. Poor prognosis. This condition has poor prognosis. It's intensive care is required in patients who have amniotic fluid embolism. No specific therapies available. Perimortem C-section performed within 5 minutes. Perimortem is the time around the death to make sure that we can save the fetus, or the effort to save the fetus is the perimortem, is the time around the death. So it's very, very poor prognosis. Patient mothers have a very, very high mortality rate. They die with this complication. So within 5 minutes, usually the C-section can be performed to save the fetus. 30% deaths occur in the first hour. Next, umbilical cord prolapse. Descent of the umbilical cord through the cervix alongside or past presenting part in the presence of ruptured membrane. So umbilical cord prolapse is very common in normal vaginal delivery. Sometimes when you examine the vagina, along with the presenting part after the membrane rupture, for a while you can see the cord coming out along with the fetal head or the presenting part. It is common in 0.1 to 0.6 of all pregnancies. Risk factors are polyhydramnias and multiparity. Second twin usually have a cord prolapse after the first is delivered. Transverse oblique lie, fetal abnormalities all these are associated with umbilical cord prolapse. Here if you see, this is the cord and it's coming out of the vagina along with the fetal head. So this is the cord prolapse. Low birth weight and podalic version also can lead to the uterine umbilical cord prolapse. Management is the signs are fetal distress is present on cardiotocograph. This is the cord that's coming out, and it's very common with podalic presentation when the feet are coming first. So there is cord coming out. Rupture of the membranes. Management is speculum examination, senior help, emergency delivery, cord compression, left positioning, and confirm fetal viability. If the fetal is fetal well-being should be confirmed. So all these are the different management steps for the umbilical cord prolapse. Another condition is shoulder dystocia. Shoulder dystocia is a condition in which the head is delivered, but the shoulder is stuck and it's hard to deliver. That's shoulder dystocia. Vaginal cephalic delivery. Cephalic delivery is when the head comes first. This is cephalic delivery, requiring additional obstetric maneuver to deliver fetus after head delivery, and gentle traction has been unsuccessful in delivering shoulders. Normally when the head comes out, it's very easy to deliver the baby, and it's spontaneously the whole baby comes out. But sometimes after the delivery of the head, the simple maneuvers that are performed to deliver the baby, they are unsuccessful because the shoulder is stuck and it's not delivering. So that's the shoulder dystocia. Complications can be maternal complications like perineal and psychological trauma, postpartum hemorrhage. Fetal complications can be brachial plexus injury, fractured clavicle or humerus is common after shoulder dystocia, and hypoxic brain injury because the fetus is stuck for a longer time before delivering the shoulder, so brain injury due to hypoxia can also occur. So these are the complications associated with the shoulder dystocia. Signs and risk factors are failure to restitute head. Restitution is the bringing the head back into the normal position. When that is failed, it's the sign. Retraction of fetal head against perineum. Risk factors, macrosomia if the head is very big, diabetes, maternal obesity, previous dystocia, and instrumental can be, all these can be risk factor for shoulder dystocia. Management is call for senior help, drop level of delivery bed as low as it will go, drop the head of the bed as low as possible, McRoberts position using one assistant on each of mother's leg. Suprapubic pressure over posterior aspect of anterior fetal shoulder. Deliver posterior arm and shoulder. Consider episiotomy. Episiotomy is the surgical cut. We talked about this, that increase the area through which the baby can be delivered easily without any tears. So episiotomy should be considered to increase the area from which the baby should be delivered. Wood screw and reverse wood screw, change position to all fours. Consider symphyotomy, cleidotomy, or Zavanelli's maneuver. These are all the different procedures which can be performed, like symphysiotomy. Or symphyotomy is the cartilage between the two pubic bones is cut to increase the size from which the baby can be delivered, and it's sometimes Zavanelli maneuvers. The head can be pushed back. That's dangerous, but if there is obstruction and the baby is not coming out, so baby can be pushed back into the uterus, and then C-section should be performed to take the baby out. Debrief staff, write notes, and risk reports. Thrombosis and thromboembolism. 10 times more common in pregnancy, either asymptomatic or specific, no non-specific symptoms occur. Signs are immobility can cause thrombosis or blood clots, dehydration or shortness of breath, cough pain. Cough pain can also is a sign of thrombosis or thromboembolism. Management is compression, ultrasound, or magnetic resonance venography, anticoagulant treatment if negative, chest x-rays, low limb Doppler, ventilation perfusion scans. All these are important in the management because thrombosis can cause complications and it can cause embolus formation also. Use of heparin intravenously, and thoracotomy or embolectomy. So this was all about some miscellaneous conditions that can cause obstetric emergencies. Thank you for watching sqadia.com.